now we're getting into the second line space, and Bob, when you're looking at a patient now that's progressed, what are the factors that you're kind of going through in your mind in sort of judging what their prognosis is now and what you're going to give them for the next treatment?
So historically, we've always kind of used a limited amount of class of drugs. We had TKIs and we had mTORs. I think when you deal with community oncologists, who the bulk of their practices is colon cancer, lung cancer, breast cancer, they've always been told to change mechanisms. It's always been, so if that we sort of use that, it was a TKI, mTOR, which is how we lived until I think through 2012. Tom Hudson tells me stories when he was back in the Cleveland clinics when they only had 2 drugs, and you got sunitinib and you got sorafenib, and when you progressed, you went back on sunitinib and you went back on sorafenib. And they still had patients who still responded. So I think that was really the foundation of a TKI followed by TKI. So the first thing I do when I have my patients, I look at the response that they had. Obviously, it's tolerability, how they handle the therapy, and the duration of the therapy that they received. I still believe that if, based upon the AXIS clinical trial, based upon the METEOR clinical trial, you can actually have a TKI followed by TKI with significant success. So if you have patient had good tolerability to the therapy, if it had significant success, and I would consider that 6 to 9 months of no progression, I may still consider utilizing a TKI. Now, we have nivolumab, and I think that we have to respect the benefit that it can offer. So when it comes to how we sequence next, I always like to look at patients' functional quality of life. Obviously, you have to make sure that they not only are tolerating the medicines well, but if they have aged in front of us. I still think the duration of response is important. I don't look so much so as for the partial response. I think that if you even looked at the temtolimus data, you can have a partial response and then progress shortly thereafter. To me, that's not a durable therapy. I mean, to me, the duration is much more important than the initial response by response itself. I think the tumor burden is going to be important. I think where they're progressing, and the organs that they're progressing in. I think if you feel this panic that they're progressing in an organ, if they get very symptomatic, I think that may make us react in a certain way. And I use the example of, I think, the Lenvima everolimus, the data was intriguing initially. I had a patient of mine who had a very good response to TKI and then rapidly progressed. And I put him on that combination, who had a remarkable response within a week. All the symptoms resolved and the tumor shrunk. At the same time, too, I've had that response with nivolumab. So again, you sometimes don't know where you're going, but you really have to recognize that it's the patient, the tumor burden, duration response, and I still have to tell my patients, and the generation has skipped already, but they still believe that IV therapy is the way to go. Pills don't work, intravenous do work. They've taken a pill, they now have had a negative reinforcement because their pill has not worked anymore, so they feel compelled to go to an IV form. So prior to nivolumab, we had temsirolimus, which I don't think was our best safety net, but now we do have an IV therapy that patients can feel a little bit more sense that they're getting real therapy compared to a pill.
And the television tells them to take that.
Yeah.
But not for that indication, for a different indication. So, and I think it's, again, not just the tumor burden, the symptoms, but, where the disease is and how rapidly the disease is recovering. So, as we talked before, it's a multitude of everything that you have to piece together. And this is really the art of how we take care of our patients is, it's not as simple as you progress, so therefore your next therapy is a given sequence.
So the issue is, if you've progressed on a TKI first line, I still think that the Cabo or Nivo are equally appropriate, but for separate subsets of patients. And Monty, Paul, and I did a meeting for ASCO review, and I use the term, cabozantinib is like my Ghostbuster drug. Who do you go to? If you've got a really bad problem, I'm going to use cabozantinib right away. If I've got a little bit more slow tempo, I'm going to use Nivo. And then if they progress right through Nivo, which, believe it or not, does happen, then I'll have Cabo as a background, or I'll use lenvatinib everolimus. Those are more or less the issues. Now, from my perspective, I'll be eager to ask you guys, if you've used Cabo up front, what do you do after an immune therapy? What do you do after Opdivo?
So after Cabo,
Yeah, so you put now Cabo up front, and now you've got nivolumab second.
right.
I would imagine. What are you going to do?
I think third line option is still not very clear. Even with say EP-Nivo coming on board, let's say the combination gets approved and you give it first line, followed by cabozantinib second line. What you do in third line? I think the question about what is the best third line option is completely unanswered right now. Nobody knows, in my view. So if I get Cabo first, I will use nivolumab second. And I don't really know what is a third line because there has not been a serious, pure third line trial we have seen. In absence of high level data, I think I will use axitinib or lenvatinib with everolimus.
Yeah, I do like the Leneve does offer a new mechanism because you're now giving an mTOR in there, plus you already have back the security of giving a TKI with that. So again, I've used it in a handful of patients, and I think literally one hand. But I've seen some patients have dramatic responses, but it is toxic. I mean, that's the problem. I've used lenvatinib when it came to thyroid cancer as well. Also, the toxicity to that initial dose, it requires reduction, as we've had with Colmetric, which was for the thyroid cancer. But I think we're learning that these TKIs are toxic, especially if you're getting them third and fourth line. So there's going to be having a dose adjustment that has to be, but yet they still have significant benefit to our patients. And I think that we should definitely believe that, as you're using axitinib, I think that moving forward, it's going to be interesting with axitinib being so well with IO combination, how we're going to eventually use that down the line too. But I think we can't forget where we came from. I mean, I'm forgetting Nexavar. I've got that. But I think that we are forgetting about
Interferon.
Yeah.
Totally forgot
So
about that.
I mentioned axitinib or lenvatinib everolimus combination because if my second line is nivolumab, I would tend to go with axitinib in third line. If my second line is cabozantinib, I don't think axitinib is going to do a great job after patient is progressing on axitinib. So I think on cabozantinib. So I think for those patients, the combination of lenvatinib everolimus would be my favored combination.
You can always think about high dose IL-2 somewhere down the line.
Right.
First line.
No,
But
I mean,
still-
there is data. I'm using it second and third line. Again, the right patient population, it's going to be a small volume about that. But again, I mean, there was data on using it second and third line on patients, again, slow-growing disease, excellent performance status patients. But again, let's not forget that high-dose IL-2 does offer a benefit even in first-line therapy. And we talked about this, that
Absolutely.
no
other therapy has a long track record of complete durable response as IL-2 has.
right. And
Yet.
back to our philosophy
And
of
we
trying,
still we are one of the few practices in the country who continues to use high-dose IL-2.
again,
Still.
it does offer our patients a therapy that may postpone the inevitability of chronic therapy. So if you do have the patient who has even a partial response, it may be quite durable, that you may postpone the need to go on a continuous therapy for years.